The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, everyone. It's Tuesday morning, and it's time for the next episode of TMD Demystified. I am Tony Urbanek. For those who follow me along, I appreciate you returning, and I hope what I have to say is helpful. And for anyone who is new to this podcast, TMD Demystified, this platform is designed to bring sanity into the treatment of temporomandibular joint disorder. Everyone calls it TMJ. TMJ is the name of the joint. Everybody has two TMJs. I have two TMJs. That goes to show you how much confusion has been out there for the better part of 70 years regarding this problem. The nomenclature is not so important. I'm not trying to make everyone wrong by bringing that to your attention, but it does exemplify how much craziness has been cranked into the treatment of, the understanding of temporomandibular joint disorder for a long time. And it is still there. I know it's still there because I get to see on a daily basis patients who have been run around in circles for decades, some of them, regarding this problem, and the inability of both the dental profession and the medical profession to properly diagnose the problem, which is not hard to diagnose and not hard to understand. Today's topic and title is Treat TMD with Coordinated Thought, Not Specialist. I had a very interesting week, and to place this in time for future reviews, the date is June 23rd, 2026. I always do these on a Tuesday morning. It is my habit, and this episode will be number 258 episodes of TMD Demystified. This one, Treat TMD with Coordinated Thought, Not Specialists. Very interesting week I had. Besides some very interesting patients I got to do on my live stream, which, to remind you, is done on Saturday at noon Central Daylight Time, noon Central Daylight Time. I do a live stream almost every Saturday. Sometimes I am traveling and cannot do it, but I was able to interview a young man, 28-year-old male from the United Kingdom, who is a fourth-year medical student with profound symptoms of TMD. He also had a simultaneous history of obstructive sleep apnea. So he had the double whammy of both obstructive sleep apnea and temporomandibular joint disorder. And I don't want to get too deep in the weeds about the relationship or lack of relationship between these two problems, because they are separate problems. There are a lot of people who have their own interest in sight that want to connect these two disorders, but they really are not connected at all. They both have something to do with your sleep, but they are not necessarily causative between one to the other. They just happen to happen. Bruxism, the most common cause of the three causes, causing temporomandibular joint disorder, which is inflammation in the joint. The disorder actually is inflammation of the joint. That is the definition of and how it should be described. TMD is inflammation in the joint, in this case, the temporomandibular joint. And obstructive sleep apnea is a totally different problem, which we now know after studying that for several decades is obstruction behind the tongue. But they both occur. Bruxism during sleep is well known, and obstructive sleep apnea only occurs while you're sleeping. It's apnea, it's lack of breathing, apneic events during sleep. So that is a connection. But does one cause the other? No. There are a lot of people who have their bias for one reason or another, conformational bias. They want to put them together. And I think I must make the unkind statement that I think, in my opinion, that a lot of this is created by the fact that obstructive sleep apnea can be covered by insurance, where the treatment of temporomandibular joint disorder is not covered by insurance. And the people who want to bring them together and make them causative are trying to make the case that temporomandibular joint disorder needs to be covered by insurance. And I'm not saying it shouldn't be covered by insurance. The problem is it isn't. And the reason TMD is not covered by insurance is because the insurance companies over the decades have found that the whole problem has been abused in understanding, having reasonable knowledge, science behind the treatments of temporomandibular joint disorder. And they have decided, both medical and dental insurance, that they don't want anything to do with it because the quote science behind it is gravely lacking. And I agree with that. Until the fact that I discovered, and I didn't make up the science, I just read the science and applied it to the temporomandibular joint, because the orthopedic surgeons created the science as to how inflammation within any joint, including the temporomandibular joint, creates the symptoms of pain. And then I also found that there is the petrotympanic fissure, which creates the non-painful symptoms of temporomandibular joint disorder: ringing in the ears, subjective hearing loss, feeling of fullness in the ears, and dizziness/vertigo. We're allowing the inflammation, again, the cause is inflammation in the joint, to seep in to the middle ear through a very short but very well-known anatomical structure called the petrotympanic fissure, better known as the Glaserian fissure, which was identified in 1680 by Dr. Johann Glasser, who was a Swiss anatomist, and put it in the anatomy books and the anatomy knowledge over 300 years ago, going on 400 years. Petrotympanic fissure allows inflammation to get into the middle ear. I didn't make that up. And the orthopedic surgeons are well aware that any joint that is inflamed causes the muscles to get signals from the brain to hold the joint motionless. So when the temporomandibular joint becomes inflamed and the inflammation doesn't go away, it sends a signal to the brain stem and says, hey, I'm sick. I'm inflamed. I'm damaged. I need help. And the brain says, I'm going to help you out. Don't move the joint. It works for hips, elbows, knees, and the TMJ. Orthopedic surgeons have known this for 50 years. The dentists don't. And they try to do things that don't make sense. And the dental insurance people and the medical insurance people know it. That doesn't make sense. So they're not going to cover it. Unfortunately, that's the way it is. And then because of that, we spill over into, because they're just trying to treat the symptoms, They make it multiple diseases instead of one disease, inflammation in the joint. They make it multiple diseases and have multiple names for it that don't make sense. Migraine headache being one of them, because medical science admits they don't know what causes migraine headaches. Migraine is just a catch-all phrase, by the way. It's just a catch-all phrase utilized heavily on TV and the internet. Anybody who has a bad headache. But if you have inflammation within the temporomandibular joint that sends out signals to the brain that says, I need help, and the brain says, tighten up, and the signals come down to tighten up all the muscles, not all at the same time, not all the same muscles, not all on the same side, but tighten up the muscles of the face, and the muscles pull on the bone, and the bone receptors at the covering of the bone create pain where those muscles are continuously pulling on the bone, periosteum, stimulating the nociceptors, creating pain, which is perceived by the patient as headaches wherever that bone is being stressed or pulled on. They'll show you exactly where the muscles are attached. They'll point to exactly where the muscles are attached that move the jaw and say it hurts right there every morning. Or, very, very common, point right in front of the joint, not at the joint, in front of the joint, deep right before, in front of that joint, is an anatomic structure called the coronoid process, and the coronoid process is the tip of the lower jaw where the big fan muscle that moves, the biggest muscle that moves the jaw is the temporalis muscle, where that is attached, and that muscle is always tender when you touch that muscle where it's pulling on the bone. And the patients will say it hurts there in the morning, or it hurts there in the afternoon, and I have a headache for 3 days. So I got to interview a young man who gave a great interview and a great description of his symptoms, because he was a medical student, fourth-year medical student, and he was used to describing, listening to, and then describing and putting down in a computer or paper a history for the patient and their symptoms. And so he did a great job of describing his temporomandibular joint symptoms, also his relationship to his obstructive sleep apnea, and more importantly, what the treatments were that he went through in Great Britain, totally different health system, and the fact that he was still having all the symptoms. Now, I'm not going to go into, I just let you refer you back to that live stream, which was done last Saturday. If you'd like to listen to it, I found it fascinating to listening to this young man speak about his symptoms and describe them to me. He was very accurate. He was a medical student. He was very accurate in describing it, and also very accurate in describing that he had still had the same symptoms after multiple types of treatment, including surgery for his obstructive sleep apnea and orthodontics for his temporomandibular joint disorder, and a few other things that he had done, just like the United States. And he was at his wit's end trying to find a solution because it was interfering greatly with his ability to study. And I can assure you, if he doesn't find a solution, being a good doctor, because these chronic pains and chronic symptoms, whether they be painful symptoms or non-painful symptoms, and he had a collection of both, ruin their lives. So really the solution needs to be a coordinated series of thoughts, not a coordinated series of specialists. And it's part of the problem. The medical schools, the dental schools, because medical schools don't teach this at all. You will not learn anything in medical school about temporomandibular joint disorder. I went through medical school. I went to Vanderbilt. I was invited by the dean of the medical school to teach my class what they needed to know about dentistry, and he gave me an hour to do it. It's like, I've talked on that before. That was kind of funny. I did the lecture and I did my best, but trying to teach young medical doctors what they needed about dentistry in an hour. It's like hopeless. So they don't know anything about temporomandibular joint, let alone anything about dentistry. But the specialists in both professions, both medical and dental, they get together and they try to figure out how to treat each and every one of these symptoms according to what their viewpoint is. You know, PCPs and neurologists and family practitioners, if you're having a pain, they're going to use a pill or refer you to physical therapy, or you yourself may want to see a chiropractor or a massage therapist. You know it's hurting. You know it has. You can point to where the pain is, and all of these individual professions attack pain. As a maxillofacial surgeon, I am a board certified oral maxillofacial surgeon, double degreed, with training in both a degree in both cell biology and gross anatomy, and 2-year fellowship in my own research project with the NIH, National Institute of Health, and National Institute of Craniofacial Dental and Craniofacial Research on facial growth and development. And it's really a matter of not having the right specialist, because you don't need a specialist. You need a doctor who understands how to coordinate in his mind the different concepts of what chronic inflammation does. And now, specifically now to the temporomandibular joint, we won't talk about the other joints in the body, but this joint operates like any other joint in the body. But to coordinate what you need to know about chronic inflammation, which I can teach any doctor what he needs to know about chronic inflammation of the temporomandibular joint and how it creates each and every one of those symptoms. I can teach that in a couple hours so that he understands it and can apply the technology of how to rest that joint, which is what the other doctors do. If you have a tennis elbow, which is the same disease as TMD, tennis elbow is inflammation of the elbow because of too much repetition, just like bruxism. Repetition of the forearm will create pain in the forearm. This will hurt if you push on it, but the problem of tennis elbow is the muscles that move the elbow. They get tight, they pull on the bone, they pull on the periosteum, stimulates the nociceptors, and the patients complain of pain all the way in the arm into the wrist, where those muscles are attached, the origin insertion of the muscles, just like the muscles of the face. The origin insertion of the muscles where they pull on the bone creates the pain. That is a simple concept. You don't need to be a specialist to understand that concept. You just need to have coordinated thought and a little knowledge of the basic sciences, and you don't have to be a specialist to treat temporomandibular joint problems by resting the joint like a sling would rest the elbow with a device that unloads the joint. It's like, unfortunately, we had to call it the urbanic device because the patients wanted to call it the Save My Life device or miracle device. That was even worse when we did that survey. It's a simple concept, but you have to have a device that you can speak with. You have to have it comfortable. Obviously, you can drink with it in your mouth. You just can't chew with it in your mouth, and you got to use it according to a protocol. Protocol, you have to keep it in long enough for the inflammation to start coming down. That's why the protocol is 24/7 for 2 months, except when you chew. You got to take it out of your mouth to chew. After you eat, you brush your teeth, you brush the device, you put it back in your mouth. Simple. And then after that, then it's nighttime only the rest of your life. And those 2 parts of the protocol will allow enough of the inflammation to decrease within the joint that both the painful and the non-painful symptoms go away. Proven with a independent university study done here in Tennessee through Middle Tennessee State University based on 3,000 patients who successfully treated with that same device. But that device has to be used correctly. The doctors have to know how to use it. The patients have to know how to use it. There are a few nuances as to when and how, and a few nuances into the issues with the problems that you can create with it if it is not used correctly. So that comes into play. But the dental profession continuously claims that this joint is different. And because it's different, they don't understand it. And because they don't understand it, then they just treat symptoms. And that is what is going on in 2026, June the 23rd, in the United States of America and worldwide, including the United Kingdom. I just proved that to myself on an interview last Saturday. The only thing that is different about the temporomandibular joint is, and this gives a little bit of space to the dental profession and the dental schools. There is a difference in this joint. I mean, any joint has a difference. You know, obviously your shoulder is a different joint than the elbow, and the elbow is a different joint than the hip. But they all operate on the same principles. They have the same principles. They have the same principles of physics, gravity, cell biology, muscle and bone physiology, biochemistry, neurophysiology, gross anatomy as far as bone and muscles go, histology, endocrinology, immunology, and vascular requirements. All the joints operate with those same principles, but the temporomandibular joint has a difference between other joints in the body, and they are two differences because a joint can operate in different manners, and this joint operates as a hinge joint or a rotation. We call that ginglimus, which is Greek, meaning hinge, ginglimus, Greek, meaning hinge. So it's a hinge joint, but it is also has a sliding motion to it. The ball and the socket of the temporomandibular joint has two motions. At first, the first half of opening is a rotation, where it rotates as a hinge, and then the second half, it moves down the slope in front of it as a sliding motion. So it has a rotation, hinge, and sliding motion. The rotation is called ginglimus, and the sliding motion is arthrodial. So this joint is a ginglimo-arthrodial joint. And that is a question that is in every examination. The final dental exam always has, your national boards will always have a question on what type of joint is the temporomandibular joint. And the wise dental student will be able to say ginglimo-arthrodial joint, and he will get that question correct. And that is just about all that is taught in dental schools about the temporomandibular joint, that it has two motions. It's called ginglimo-arthrodial. Go out and do good dentistry. That is the summation of what's taught about the temporomandibular joint in dental school, unfortunately. And then if you have the problem and you go to your physician and say, I'm having all these strange pains, the physician will say, go see your dentist, who knows how to call this joint ginglimo-arthrodial. That's the state of the temporomandibular joint in 2026, unfortunately. So it really takes a coordinated thought process to understand and treat the joint correctly. It's not complicated. You don't need a bunch of specialists, and you certainly don't need a lot of drugs. You don't need any drugs. You need to know that sometimes you have to fix a bite that is a functional malocclusion, which is one of the other causes of damage to the joint. If you have a bad bite to start with, you can create damage within the joint. If you have an automobile accident, and especially whiplash injuries, you can damage the joint, which cause chronic inflammation. If you brux and clench or grind night or day, or both, you can damage the joint. All three of those things cause chronic inflammation. Chronic inflammation causes all of the symptoms. So you don't need a bunch of specialists treating symptoms. And my final comment for today, I want to talk about Botox, botulinum toxin A. But it is such common, everybody calls it. It is a direct confrontation of the Botox company, but they made the fact that it is so well known that everybody calls the entire drug category Botox, whoever makes it. And Botox now, as I have found out recently in the past week or so, even for the use of facial reconstruction or facial rejuvenation, the folks, the spas, health spas that use Botox are promoted, and now dentists are using it frequently. There's so many stories. It is dispensed like water now frequently, and the problem is I am learning that the people have been using it, actually injecting it in others, have found that over time it causes continuous muscle relaxation and cosmetic deficits rather than improving it. When you stop using the Botox, you get muscle sags. And of course, I am a little older. We could definitely use some surgery if I wanted to do that, but Botox is not the way to go because it causes damage to the underlying structures, which causes sagging over time, which is just the opposite. It will paralyze muscles. And as you know, it has to be repeated every 3 months or so. And that's the problem. You repeat it too often and you start having really bad problems with muscle sagging, muscle too much relaxation causing cosmetic deficits rather than improvement. And it's being used. I just heard from firsthand knowledge that injections for temporomandibular joint issues, which the dentists are doing more commonly now, was done by a ophthalmologist who I assume used it around the eye, but had a patient. This was firsthand patient. I said, who injected your Botox? And he said, an ophthalmologist injected my Botox for temporomandibular joint issues, trying to paralyze a muscle. It hurts there, doc. It hurts there, right there. So you paralyze the muscle for 3 months. That muscle is not going to it's not going to contract. It's not going to pull on the bone. But what about the other side? What about the other muscles? What about the non-painful symptoms? They're still going to be there. You got to attack the cause, not the symptom. All right, I've gone on probably a couple minutes too long here. I hope what I've talked about is meaningful. If you'd like to learn more, if you are a patient, you can direct your dentist to go to www.urbanictmj.com and look at our website. If that dentist would like to participate and use this device and learn how to use it, they have to take a course, short online course, 3-hour course. We'll teach them how to use it correctly, teach them how to teach their patients how to use it correctly. And you can have your dentist go to that website. If you are someone with symptoms and you believe you might have temporomandibular joint disorder, we have the list of other doctors in the United States, growing list. Most of them admittedly are in the eastern, midwestern, southeastern part of the country at this time. And that's why you can, if you're on the other side of the country, just tell your dentist to take the course and he can use this very simple device for you and his other patients. It'll be outstanding. I look forward to the next time, next Tuesday morning. I'll speak again. We'll pick out another topic. I'll share something with you. I hope it'll be meaningful. I hope whatever I said is helpful. That is my purpose in doing these podcasts. I am Tony Urbanic, and this is TMD Demystified.